Good evening, everyone, and welcome to this evening's webinar on public health in the United States, past, present, and future. My name is Peggy Crane. Just so I tell you, I'm going to be the moderator of this evening's discussion. Before we begin in earnest, I'd like to say a few words about us. We are the New York City branch of the Living New Deal, which is a national nonprofit based in California. In normal times, we're pretty New York centric. We hold events here and run tours here, and we've been creating signage to mark New Deal sites here, starting with 11 WPA swimming pools located in parks across the 5 boroughs. But ever since the pandemic drove all of us indoors, we've been hosting events that have relevance far beyond the city's borders. COVID looms large in all this, and it also looms large for our discussion this evening. So before I introduce our first speaker, let me just share a 360-degree view of the coronavirus that appeared in a brilliant article by Ed Yong, one of my favorite science writers, in The Atlantic last spring. Yong names the many aspects of 21st century life that made the pandemic possible in the first place. Humanity's relentless expansion into wild spaces, soaring levels of air travel, an economy that runs on fragile supply chains that has everything to do with shortages in PPE and in the vaccine itself. Healthcare systems that yoke medical care to employment, social networks that rapidly spread misinformation, the devaluation of expertise, the marginalization of the elderly, centuries of structural racism that impoverished the health of minorities and indigenous groups, and chronic underfunding of public health itself. He concludes, quote, "It may be easier to believe that the coronavirus was deliberately unleashed than to accept the harsher truth that we built a world that was prone to it, but not ready for it." Obviously, we won't be able to tackle all of these issues in a single webinar, but what we can do is share the little-known history of the New Deal's achievements in promoting the health of the nation and use it to point to the kinds of reforms we need to meet the challenges we face today. So let's travel back in time to the 1930s with a presentation by Deborah Gardner, historian and curator for Roosevelt House at Hunter College here in New York City. She's also a key member of the Living New Deal New York City's working group. To you, Deborah.
Okay, thank you, Peggy. Welcome, everyone. I hope I'm going to speed through a slide presentation so that you can see the public health history of the New Deal. So, President Roosevelt cares for the people, health in the New Deal. Health was an important part of the New Deal, which doesn't often get the recognition that it deserves. It was really central to much of what President Roosevelt thought about during those dark days when he took office and the nation had been in a depression for several years. In his inaugural speech, he talked about the grim problem of existence and the dark realities of the moment. And one of his most famous catchphrases from that inauguration was speaking of 1/3 of a nation that was ill-housed, ill-clad, and ill-nourished. And if you add those 3 factors together, you can understand how people's health was suffering. 40 million people didn't have enough food, nor did they have medical care. And in speech after speech, throughout his presidency, FDR would have as a mantra the need to have a healthy nation. Personally, he knew how important good health was. Here he is in a wheelchair. He had lost the ability to walk, having suffered from polio in 1921 when he was just 39 years old. He had good care, good rehabilitation here at Roosevelt House. And he had, even by the time he became president, started to make care available to other people who suffered from polio, who didn't have his resources. And so what he would do again and again would be to try and provide resources for people who didn't have them. He wanted to fund health programs in the Social Security Act. In the center of this picture, you can see Francis Perkins, who was the Secretary of Labor and a big proponent of Social Security, unemployment insurance, and health care, all to be provided by the government. But as she later wrote, powerful elements of the medical profession were up in arms over the idea of any kind of government-endorsed health programs. So the compromise was to implement Social Security and unemployment compensation and federal aid to dependent children, but to provide money to the states in order to enable them to develop health programs. And the initial funding was for $100 million, with today's $1.9 billion. He reaffirmed health as a fundamental American value in speech after speech. The health of the people is a public concern. Good health is essential to the security of the nation. And finally, in 1944, he would state in his new Economic Bill of Rights that the right to medical care and the opportunity to achieve and enjoy good health was fundamental. And then this would be carried forward by his wife, Eleanor Roosevelt, who also believed that proper health care, good health care, should be available to everyone. And when she went to the United Nations and later wrote the Bill of Rights, the Human Rights Bill of Rights, good health care, medical care was included. In 1940, we cannot be a strong nation unless we are a healthy nation. And this was at the dedication of the National Cancer Institute. The government was putting more and more money during the New Deal into scientific research, something it had not done before. Now, many New Deal agencies were involved in providing health care in one way or another. All of the major construction programs, like the PWA and the WPA, the power agencies, like the TVA, the human resource agencies, like the National Youth Administration and the Civilian Conservation, the electric power agencies, the art project, the agricultural department, all were involved in one way or another. And the result was the construction of many new large urban hospitals. Here you can see the Jersey City Medical Center, which was the largest in the world by the time its construction was completed in 1941. And it offered free medical care. Other urban hospitals did the same. On the left, you see the large St. Louis Hospital. On the right, the Pittsburgh Hospital, where 2/3 of the people there received free care, whether they were inpatients or outpatients. Other large urban hospitals built during this period was Bellevue in New York on the upper left, and the Charity Hospital in New Orleans, which was operational until done in by Katrina. And you can see what a huge complex it was. Now, I would say that all these government agencies were involved in healthcare in one way or another, saluting the healthcare professionals, the essential workers, were murals done by artists hired by the Federal Art Project. And here you see two of the famous series of murals done at Harlem Hospital in New York. Now, in addition to the large hospitals, many, many public health clinics were built. Here is one on the left in Williamsburg in Brooklyn, and there were 7 or 8 more built throughout the city in low-income neighborhoods to try and address the healthcare needs of low-income city residents. There was a special emphasis on prenatal care and reducing infant mortality and encouraging vaccination, all aspects of care. Now, the clinic on the right is smaller, but it was still important in Tallahassee, Florida. And what was interesting was the alternate days white patients and African American patients. Most of the hospitals in the South were segregated, just like many other projects during that period. So this was another way to provide medical services to everyone, but even in some hospitals, one floor would serve white patients and another floor would serve African American patients. Now, artists through the Federal Art Project prepared all kinds of materials, advertising materials for public health campaigns. And you can see several of them here about safety in the workplace, taking care of yourself. Public health campaigns also focus on better housing, getting people out of the tenements and the slums into new housing, because it would mean better health for people than could be gotten in these old 19th century tenements. Public health education is also important. Here you see a poster where there would be a discussion of air pollution, a poster reminding truckers about where they would pick up milk, avoiding places where there were highly infectious diseases, and of course in health education for people to take. There were also specific disease campaigns. Syphilis was a huge problem across the country, and so there were many campaigns, city by city, to try and get people to come in and be tested and be cured. It was a menace not only to people who worked, but also to families, to children, to wives. It also could cause blindness in children, and so people were supposed to come in and get treated. Other public health campaigns also targeted tuberculosis, another endemic disease. Get tested. So the origins of today's test for COVID go back many years. Once you were tested, you could be treated. Well, they didn't have antibiotics at the time. Nonetheless, there were treatment regimes to help people. Vaccinations, also very important for people. Diphtheria, smallpox, whenever something new came along, there would be another campaign. Public health also targeted eating, better nutrition, especially for mothers, expectant mothers, nursing mothers, for children, and the origins of the food stamp program also started in this period. Education for taking care of children was also part of the public health campaign. And here you see a class about caring for babies with looks like some pregnant mothers to be. Better nutrition was especially aimed at children, and a free lunch program was also started in this period. There were messages about cancer care. Well, cancer care and treatment certainly wasn't what it is today. Nonetheless, with early detection, it was possible to cure certain kinds of cancer. So encouraging people to come in and get checked. Public health delivery was very creative. There were mobile clinics, which often went to migrant camps. There were home visits by nurses, and there were healthcare aides to help families where the mother in particular was unable to cook or eat because she just had a baby or she was ill. There were specialized hospitals. Tuberculosis hospitals, because of what I discussed before. It was an endemic disease. People would come. These hospitals often had balconies. Fresh air was very important. And other kinds of specialized hospitals besides tuberculosis, more of which you see here, including a segregated one in Arkansas. There was home quarantine, these little cabins or sheds that could be moved from home to home, where a patient could sequester until a hospital bed opened up, and then they'd be moved on. And then in tuberculosis, a camp for children, as well as a new hospital for African Americans in Washington, D.C. Other specialty hospitals were those for the major immigration detention centers, one in New York on Staten Island, one in Honolulu, and then specialty hospitals for regional diseases like leprosy in Louisiana, and trachoma, which was a bacterial infection of the eye, which was across a number of states, with Missouri sort of central in that southeast area. And trachoma could cause blindness, so there was a great effort to get people treatment, as well as to do other health measures to prevent insects from spreading it, as well as person-to-person contact. Not surprisingly, there were hospitals for military veterans, a new one in Bethesda, Maryland, the Naval Medical Center, which you see here on the right, and cancer hospitals also. In addition to these large hospitals, many areas received small rural hospitals where there had been no healthcare before, no organized free healthcare. And you see several of them here in Texas and elsewhere. And there were also local clinics in American territories, the Virgin Islands, and also Puerto Rico, which had been devastated by a hurricane several years before the New Deal started. And it needed all new health facilities. So it got clinics and hospitals, as well as hundreds of millions of dollars to help rebuild not only hospitals and healthcare, but housing and water systems. Public health labs also got funding. They were very important in terms of tracking disease in various locations, various states, and also trying to find cures. Physicians' care was made available, and a number of the Farm Security Administration rural settlements, healthcare clinics were built, and people could subscribe $2 a month for a family to get all the medical care that it needed. And here you see two doctors in Illinois and West Virginia caring for people either in the clinics or at home. They still had home visits at that time. Now, another major effort to improve healthcare was to improve water supplies in big cities, small cities, towns, and so forth. Huge investment in building all aspects of the water system. These water tanks, also in eliminating standing water, because that led to disease like malaria, which was spread by quarantine. So there was a huge investment in construction of water provision, water filtration, and water pollution and water delivery systems. Reservoirs were built or improved. Sanitary outhouses were built because without them, there were all kinds of flies like those that spread trachoma, which would fester in the primitive outhouses that people had. And so, as you can see, this sign talks about keeping flies away with deadly disease germs. Water systems were large and extensive, and New York was so proud of it that it built this huge display for the New York World's Fair in 1939, showing the total water system from the city of New York going up the Hudson into the Catskills and the Adirondacks, providing clean, fresh water to the city. Water filtration plants were built to improve the water before it was dumped into neighboring bodies of water, where often that same water would be taken out to provide drinking water for people. So wastewater plants were very important. New sewer systems were also extremely important, being put in when none existed before to provide clean water. And here's some more wastewater treatment systems. Many of them look very similar. And then another aspect of water provision was pools. Outdoor recreation was considered a way of fostering public health. Here you see two large pools of 11 that were built and opened in the summer of 1936 in New York. But here you see a poster, swim for health in safe and pure pools. Treatment pools for polio patients, for example, were also built in this period because that was part of the therapy routine, which President Roosevelt endorsed because he himself had benefited from that. So the rights to adequate health care and the opportunity to achieve and enjoy good health was a part and parcel of every aspect of New Deal activities. And thank you for coming to this program, and please visit us at either the Living New Deal site, where you can see many other health-related projects from around the country, or come to Roosevelt House and look at its programs on the New Deal. Okay, I'm done.
Fantastic. Oh, thank you so much for that. Boy, it sure does make a difference to see these unbelievable images, photographs, posters. In fact, I just kept thinking, I'll bet, I mean, obviously now we would do everything on social media, but maybe something has been lost. A poster campaign encouraging people to get vaccinated could be quite effective. At least that's what I think. Anyway, this is really great. So let me move along and introduce our keynote speaker. Sandro, are you there? I hope he's here. There he is. Hello, Sandro. This is Peggy. Here I am.
Hello, Peggy.
So glad you can join us. I'm really thrilled. I'll just introduce you very quickly, and then you can take it away. This is Dr. Sandro Galea, who is a physician, an epidemiologist, and an author. And he is also Dean and Robert A. Knox Professor at Boston University School of Public Health. He has held numerous academic posts, which you can probably read about in the e-invitation I sent you. So I won't repeat those here. But just to say that he has been listed as one of the most widely cited scholars in the social sciences, which is kind of amazing. We just feel so lucky to have him tonight. So I will cede to you, and I'll see you later, but please, to you, Sandro.
Well, thank you so much for having me. Thank you, Peggy, for inviting me. It's really a privilege to be here with you all. Let me share my screen, and there we go. So Peggy asked me to speak about this notion of a health new deal in a post-COVID world. And I want to make the case that in the context of COVID, there is an opportunity for radical rethink of health based on, not based on anything new, but based on a surfacing of issues that have long been with us and that COVID COVID has made abundantly clear. So, I'm not entirely sure why Peggy reached out to me, but I thought it was perhaps because of this piece that I wrote about last year, arguing for a health new deal. And this was before COVID. This was in March of 2019. And I was really trying to make a case that we need to rethink how we think about health. And I suggested that thinking of a rethinking about health as a wholesale transformation in our engagement with health could be a positive way forward. So what do I mean by that? And let me start off with understanding health. Now, I realized that you just were listening to this excellent presentation that came before mine, and so everybody here gets health, but it's helpful, I think, to just go back and say, well, what exactly do we mean by health? And I think it's helpful to talk about health by talking about a story like this. This is a story of Blind Willie Johnson, who is, for those of you who know the blues, Blind Willie Johnson. He was a bluesman, and he was born in Texas at the turn of the 20th century. And he grew up sighted, but he lost his eyesight in a domestic violence incident when he was 7. So he grew up poor and blind and black in Texas in the early 1900s. He got married, was living in a house. His house burned down, and him and his wife didn't have any money. So when the house finished burning down, they went back and were living in the rubble of the old house. In his early 40s, Blind Willie Johnson got malaria. And now this is Texas in the 1940s. Malaria was not that uncommon. Many of you will know that the Centers for Disease Control, for example, CDC, was started to deal with malaria in the southern states. And his wife took him to hospital, and he was turned away from hospital, and then he died. So the question is, what killed Blind Willie Johnson? Well, what killed Blind Willie Johnson was malaria. Had he received treatment for his malaria, he would have lived. But when I tell you that story, you realize that wasn't just malaria that killed him. What killed him was malaria, yes, but also poverty and homelessness and racism and domestic violence. All these forces also killed Blind Willie Johnson. And I think that tells the story of health. I think it tells the story of health effectively, because it says very clearly that health does not exist unless we deal with the forces around it. And if we only focus on malaria, we are all going to have premature lives. And that's what a health new deal is. It is actually saying health is the product of all these forces, and we need to focus on all of them equally, perhaps more than we do focus on malaria. Now, I'm telling you this by way of anecdote, but I could equally tell you this by way of theory. This is a fairly common figure from the Institute for Clinical Science Improvement, showing that medicine and healthcare are responsible for 10-20% of health. But health behaviors, smoking, drinking, exercise, physical environment where we live, work, play, our jobs, our education, our family supports, those are responsible for the other 90% of our health. Now, you may all understand this, but this is, of course, not how we operate. It's not how we operate at all. If you take the previous diagram and put it in the figure on the left, those percentages are the same percentages I showed you in the more colorful figure before. Well, although medicine is about 20%, maybe 10%, 20%, we spend 90% of our money actually on medicine. So it's like saying, you get the Blind Willie Johnson story, you don't have an argument with it, but you say, okay, you know what, ignore everything else. Let's just spend all our money on malaria. We just spend everything on malaria. That's fundamentally what we do. And of course, we spend a lot of money. We spend a lot of money on health. This is spending in the United States and all other high-income countries on health. You see all countries are going up on health, but these colorful lines here are all other high-income countries. This is us. We spend about 40% more on health than do all these other countries. And as we're doing that, we're spending less and less on everything else. The light blue bar here is exactly the same thing as I showed you before, spending on healthcare. Social Security is the bottom, and we spend less and less on everything else. Now, this is not just happening, it's happening everywhere. I'm speaking from Massachusetts, where I live. Massachusetts, thinks of itself as a very progressive state, which it is in many respects. It's almost like another Canadian province. But even in Massachusetts, look at spending over a 15-year period. We spent more on healthcare, but 100% more on healthcare, less or the same on transportation, housing, primary, secondary education, law enforcement, public safety, mental health, higher education, early childhood education, public health, environmental recreation. That's in Massachusetts, and you can imagine what it's like in other states. And of course, this has had a net effect. This has had an important effect on us. It has an effect, namely, in our overall health that has suffered. This is life expectancy. You see all the other high-income countries getting ahead of us. We've essentially leaving 5 years on the table in terms of life expectancy. We choose to die 5 years earlier than everybody else because we take this approach. Now, we Don't think you may not think, well, this morning I chose to live 5 years less, but we did. Every single day we are choosing that. We as a country are choosing that. And that is exactly for the very simple reason that we're spending all our money on malaria, not on everything else. We should be spending our money on the world around us, in education, on nutrition, on parks and places for recreation, on making sure that we're not in poverty, on stable housing, on dealing with social isolation, on better environment. When you distill all of this into one slide, you get this. The slide at the x-axis, you have spending on health. On the y-axis, you have life expectancy. And you see all these countries, all other countries, you spend more and you get more. US, we spend more and we get less. I ask you this question, name one other sector where we are willing to spend more than all other countries and get less out of it. There is no other sector. Imagine if I told you your phones were more expensive than all other countries' phones, but they're slower and the bulkier. Wouldn't accept that. So this is the world that we're in, which is where we are accepting on health a deal that is not a good deal at all. Now, coupled with that, our distribution of assets that produce health is uneven, that we allow ourselves to have this uneven distribution of assets that creates underlying divides, that create health divides. So just to give you a concrete example of that, this is household income. Household income in this country has gone up only for the richest 20% effectively in the past 40 years. Everybody else has stayed roughly the same, which is really quite remarkable when you think about it. And now this is just income. Of course, that income is then immensely distributed by this overall income by race. This looks at income stratified by education and by race, showing that at every education level, white Americans' income is higher than Black Americans' income. Highest income is higher education among white Americans, lowest income less than high school diploma among Black Americans. Now, this is just income. I don't even touch wealth. Wealth is even more unevenly distributed. So this is wealth on white families, Black families. On the left, you see overall very little increase over the past 40 years because only 20% has increased. But white Americans have about 60% more income than Black Americans. Look at the wealth. It's about tenfold difference between white Americans and Black Americans. And that difference exists at every level of education. You see it even post-college education, college education, white Americans have more wealth than Black Americans. At every level of income, see it income, higher income, middle income, lower income, white Americans have more wealth than Black Americans. And remarkably, this gap has actually been growing because if you look at this, 1983 versus 2016, overall is on the left. You see wealth has roughly stayed the same overall. White American wealth has increased over the 40 years, 1983 to 2016. Black American wealth and Latin American wealth has essentially stayed the same or gone down, which means the gap has gone up. And this unevenness in distribution of resources that, as I'm going to show you in a second, become health maldistribution, goes back to the history of disenfranchisement of Black Americans in particular. I mean, Americans of color in general, but Black Americans in particular, going all the way back to slavery. This is a map of slavery in the 1860s, which really became then forms of institutionalized racism that became, for example, redlining. This is the Homeowners Loan Corporation redlining map, which was really a federal system of marking neighborhoods that were eligible, thought to be eligible for viable for loan, for lending, and areas where African Americans lived were marked in red, hence redlining, to say don't invest in those areas. And that, of course, resulted in patterns of segregation that exist to this day. This is Detroit, the same map I showed before, looking at green dots, blue dots, Black Americans, white Americans, showing this amazing segregation across neighborhoods. So message A is we underinvest in the resources that create health. Message B is that underinvestment is unevenly distributed across socioeconomic groups and racial groups. And that becomes health divides. That becomes a consequent health divides. So we have, this is life expectancy overall, white, Black, the difference in life expectancy, about 4 to 5 year difference in life expectancy, which means, by the way, Black Americans compared to other high income countries, have about a 10-year difference now, because we have about a 5-year difference from white Americans, and overall we have another 5-year difference with other high income countries. So Black Americans have about a 10-year difference in life expectancy compared to other countries. Coming back, I'll go back to the map of slavery that I showed you before. Remember I showed you the map of slavery that was in sepia, sort of old-timey map. This is the exact same map now rendered in geographic information systems. The darker the color where there were more slaves in 1860. The reason I rendered this in GIS is to show you that this maps onto the stroke belt. More where there were more Black Americans, slaves, you have more strokes today. And I could go on and on to show you about the differences in risk factors and health outcomes among African Americans versus whites, this mortality rate at different ages, younger ages, middle ages, older ages. High blood pressure, diabetes, same thing, more black versus white. And of course, so I go back to things like segregation I showed you before. This is the map of redlining I showed you before that maps onto the red colors, map onto greater density of home foreclosure, map onto the greater density of poor health thereafter. So we can link these things together. That's by race, and I can come back and tie it to socioeconomic differences as well. This looks at the richest 20% of Americans, the poorest 80% of Americans. Remember, income has only gone up for the richest 20% of Americans. It's a very natural cleavage point in our country. And what you see here, richest 20%, lower congestive heart failure, angina, heart attack, stroke than the richest 20%. And amazingly, not only is it lower, those gaps are getting wider. You see over time, over the past 20 years, richest 20% of Americans, poorest 80% of Americans, the gap getting wider where the health gaps are getting wider. And the health gaps now have widened even over a 15-year period. Look at this. Congestive heart failure. This was the gap in turn of the century. This is the gap 5 years ago. Turn of the century, no gap in angina, gap now, and on and on and on. Race, socioeconomic cleavages in the resources that generate health, in the resources that in blind Willie Johnson's life characterized his life that we know resulted in his malaria and his death. And bringing socioeconomic status and race together is this graph. So these are four different forms of poor health, but just focus on asthma. They all behave the same way. Just focus on the middle. These are census tracts in the US. X-axis is the income. Y-axis is prevalence of asthma. So what you see here is, right, there's a best fit line through these dots, which means higher income, less asthma. But then what I like about this graph is that it colors the dots by density of the share of the black population. More purple, more black population. So what you see is there's an overall income gradient, but then the African-American population is concentrated at the low income, higher asthma. That's how socioeconomics and race come together in this country to create a pattern of unevenness. So then COVID happens. COVID hits, and what does COVID teach us? How does COVID create a path for a health New Deal? Well, COVID has ravaged the country, as we know. We're now in perhaps the third wave of the pandemic, and that has resulted in things like this, and scenes like Times Square being emptied out, as you all know. It's also has resulted in amazing drops in employment. This is employment, lowest level of employment since 1975. And, oops, I apologize. And a economic downturn in employment that is differentially affecting people. In fact, for high-wage Americans, unemployment has essentially gone away. We're back to full employment. For low-wage Americans, we're still about 20% lower in unemployment. And that's true for Hispanic Americans, which had the steepest initial employment losses and still have ground to make up post-pandemic. White Americans, and Black Americans, which have lost more jobs and have recovered only about a third of jobs that they lost during the pandemic. I'll skip that. And what's amazing about this is that this pandemic is different. It's different. This recession is different than previous recessions, in previous 2008, 2001, 1990. The coronavirus crisis, what you see is it affects lowest earning Americans disproportionately, while other recessions have affected all of us the same way. And the reason for that, of course, is because the coronavirus crisis has affected financially our mobility and our capacity to get on in the world, which fundamentally limits those whose jobs require them to have different types of exposure, which I'll get to in a second. It is then no wonder that in the middle of the pandemic, in the middle of the economic crisis, we saw the largest civil unrest the country has ever seen. And the protests in 2020, civil protests in 2020, triggered by, of course, the murder of unarmed Black men and women, but really fundamentally were about much deeper issues. They were about issues of deep racial divides and socioeconomic divides that have been there in the country for centuries. So COVID hit, and COVID has had an unequal effect divided by the same lines that I showed you before. COVID, this Black American death disproportionate in COVID compared to white death. But right now it's about 1.5 times death of Black Americans compared to white Americans. And you all know that, you've all heard it, but it's important to ask why. Why is that? Like what happened? What is it about our underlying structure that resulted in that? Well, the way to answer that is to look a bit more carefully. And these are multiple jurisdictions, but let's just focus on DC here. Just focus on DC for a second. And there's Black Americans, white Americans. And the blue is percent of population, the orange is percent of COVID cases, and the gray is percent of COVID deaths. So what you see here is that as a percent of population, This is Black Americans. There are more cases than there is percent of population, and then there are more deaths than there are cases. White Americans is the opposite. There are more population than there are cases and more cases than there are deaths. What that means is that there are two different steps. There are risks for acquiring the disease and risks for getting sick if you acquire the disease. And those are two different sets of risks. So what are those sets of risks? Well, those sets of risks are quite different. Number one, here's the good news. There's no evidence that this risk comes from once you're in hospital. In other words, the treatment of malaria, to use the blind Willie Johnson example, has been equitable. There's no evidence that once you're in hospital, that Black Americans or white Americans or Latinx Americans are dying at different rates. That's good news. But what it means is there's something else going on. What's going on? Let's start with the risk. Let's start with getting the disease. Well, to get the disease, to get COVID, you need to be exposed to COVID. And to be exposed to COVID, you need to be around other people. This is from a paper that we published in Nature, which looks at smartphone use. So when you look at smartphone use, and this is by income quintile, and what you see here is this is the fifth income quintile, and these are people who, smartphone users staying home all day. The richest quintile, the fifth quintile, was actually not staying home very much, and then all of a sudden, COVID hit, and all of a sudden, the richest quintile is staying home much more, while the poorest quintile is staying home less. Similarly, working outside the home, richest quintile all of a sudden starts working, is not working outside the home, while the poorest quintile remains working outside the home. So we know that ability to work remotely is highly socially patterned by income. This is the top 25% income quintile. See, dose-response relationship. The more money you make, the more likely you are to be able to work inside your home, which means, of course, the less money you make, the less likely you are to be able to work inside your home, which means the more exposed you are to the disease. And this, of course, is also linked to race, that Black African Americans are more likely to be employed in essential industries. So step A, greater risk of disease because of greater risk of exposure to disease. Step B, once you have the disease, why are you going to get more severe disease? Well, that's a different set of factors altogether. Here's a graph that looks at by income decile, all going this way. The yellow line is having prior illness that makes you vulnerable to COVID. The green line is having prior mental health condition that makes you vulnerable to the mental health consequences of COVID. The richer you are, the less likely you are to have underlying health conditions or underlying mental health or underlying physical health conditions. And we've known from the beginning of COVID that perhaps the likeliest way you are to die from COVID, if you get COVID, is by having underlying conditions. This is from the earlier studies from China CDC, showing that underlying cardiovascular disease, diabetes, chronic respiratory disease, older age, that is all associated with greater risk of dying from COVID. And if you are minority, particularly Black American or low income, you're more likely to have these risk factors. So just focus on the right panel just for ease. Lower income, more risk factors across the board. So that means that once you get COVID, you're more likely to get severe COVID if you are a minority. And that's why the gap, the race gaps in mortality are actually wider at younger age group. The blue here is white, the orange is Black, the gray is Latino, Latina. And what you see is there's a wider gap in mortality at younger ages than there is in older ages. Because of course, by older ages, you have comorbidity among all different race groups, not just among Black Americans or Latinx Americans. And this, by the way, carries out to all forms of health, not just physical health, but also mental health. So if I just talk about mental health, this is depression in the context of COVID. It's from a study we did published in JAMA. The blue bar is before COVID. The red bar is during COVID. What you see is fewer people with no COVID symptoms, with no mental health symptoms during COVID, more people with mild, moderate, moderate, severe, but a threefold increase in depression. That's in the general population. But remember, I showed you underlying depression, which has a precedent, which antecedes risk of depression. And of course, that means that it is the people with fewer assets and more stressors who are going to have depression. This is high assets, low stressors. These are people with low assets, high stressors. There's a fourfold difference in your likelihood of depression during COVID if you have savings, you have your own house, you have your own car, you're able to look after your children, you're not worried about your parents. Fourfold difference in risk of depression in the context of COVID. So I want to end here because I want to make sure I left time for questions and comments. So what is this notion of a health new deal? Well, I think the notion of health new deal is not where I fear we're going in the context of COVID. You know, this was a cover of Time magazine in 2017, which said we're not ready for the next pandemic. They were, of course, right. But if you look at the issue of Time magazine, what was it about? It was about better biosurveillance, better technology, better biologics. Yes, that's all true. But what I really think we fundamentally need is to rethink how we think about health. All of this is about treating malaria, in this case, COVID. It's the same thing. A health new deal fundamentally requires health and health policies, making sure that all sectors are incentivizing health and changing the story of health. This is a quote from Edgar Seidenstricker, which some of you may know. It's he was a sort of a discovered pellagra. Said someday the basic criterion of any condition or any practice or proposal will be the effect it may have upon the public's health. The good news is that he said this. The bad news is that he said this almost 100 years ago. But fundamentally, I think that's what we aspire to. So I'll end here. I'll end with the best metaphor I can think of for what I mean by a health new deal, which is I'm ending on the sport I care about, which is soccer. I know yesterday was the Super Bowl of the other sport called football, but that's not real football. This is real football. The US is blessed to have the world's best football team. That's the US women's national soccer team. And that's the soccer team here. For those of you who don't know how soccer is played, you have 11 people on one side, 11 on the other side. The aim of the game is very simple. You have to score a goal into the net on the other side. It's a very simple goal. If nobody scores in your goal, you're always going to win. If you can keep the ball in your net all the time, you're never going to lose. Okay? So suppose I tell you that. I say, look, construct the best soccer team you can. I'll give you $1 billion, construct the best soccer team. And you say, I see. But if nobody scores on me, I'll never lose, right? Yes. So here's what I'm going to do. I'm going to use $1 billion just to spend it all on the goalie. Get the best goalie in the world. The goalie is the woman in the black. And you say, that's all I'm going to do. I'm going to invest in the best goalie. And then you still lose. And you're like, why is that? Well, when you watch a professional soccer match, what you see the goalie do, that's Alyssa Nair, the woman in black, she's walking around in front of her net and yelling at her fellow players. And she's saying to them, keep the ball away from me. Now, why is she doing that? Because although she's a very good goalie, the net is very big, and she knows that no matter how good she is, a ball that comes at her fast enough, somebody's still going to score. Because to win, you need the other 10 players to move the ball upfield and to score for you. You can't rely only on the goalie. Why am I telling you this? I'm telling you this because the goalie is medicine and healthcare. A health new deal says we invest equally in the goalie. Yes, we invest in the goalie. It's not an argument against the goalie, but we also invest in education, in equitable wages, in gender equity, in clean environment, in reducing social isolation, in reducing domestic violence, all those forces that ultimately generate health, all those forces that created blind Willie Johnson's life, all those forces that contributed to what happened in time of COVID. And really, I hope that in time of COVID, this is the opportunity we've been waiting for to make this argument and make it stick once and for all. I will stop there. Thank you for having me. I look forward to your questions. I think you're on mute, Peggy.
Mute myself? Yes. Thank you so much, Sandro. I will tell you the story of how I found you later, but an interesting story. But in any event, this is just a remarkable, remarkable evening. And the questions are starting to come in, but before we go into the Q&A, we have a couple of fantastic panelists to comment on your remarks and to possibly add some of their own. I know that this group is in high agreement, so I'm not expecting any strange and interesting things coming from left field, but please let me introduce our first panelist, who her name is Carmelita Blake. She is a nurse, a hospital administrator, and recently retired clinical associate professor at NYU's School of Continuing and Professional Studies. She's actually, the most interesting thing I've heard said about her is that she thinks and acts at the intersection of public health, nursing, and meeting the health needs of underserved populations. So that is sufficient for the moment. You can read her biography on the e-invitation that I sent out to all of you. Please, Carmelita, to you. I think you need to be unmuted. Let's see. Hold on a second. Just a moment.
I think I may have unmuted myself.
Ah, there you are. Okay.
Dr. Galea, thank you very much. That was such an excellent presentation. I really can't say that I have much that I want to add to what you have just said. It was very extensive. I would, though, like to say that we as healthcare professionals also have a role to play. And I know you talked about education. And one of my focus is that we need to look at the health care workforce, and we need to care for them as well as we care for our patients. And we also need to make sure that they themselves stay educated. I think COVID-19 has pointed to the fact that we all as healthcare professionals now need more in terms of palliative care. And especially in these times when, because of the pandemic, we are not really able to use the, as we want to call it, the health team at all times because of the crisis that has been created by the pandemic. If I say education, and I would agree with you that education has been impacted in every way, from the students who are in elementary and high school and universities to students also in medical schools. But I think we also need to keep in mind that the pandemic has shown us that we still have healthcare shortages, and we still have an unequal distribution of health professionals. So when we talk about vaccine hesitancy, we're looking at individuals who probably for themselves, they're not interacting with health professionals who look or speak in the same languages that they speak. And I think for a lot of people, that makes a big difference. I said earlier that even during the pandemic, we need to focus on who the messengers are and what is the message we want to really share about public health. And I think that Deborah pointed out that during the 30s and 40s and even the 50s, there were campaigns with posters. We are a highly technological society now, but we still have other ways in which we can mass interact with individuals at every age, in every community, and at all times. And I think that's some of the things that we really need to do. Going back to caring for our own, we have seen an increase, and I think you mentioned depression. There is such a large increase in mental health issues among healthcare providers. I'm a nurse, even though I'm currently not practicing. I tell people I'm licensed and I keep active as far as nursing is concerned. And we have them as our unsung heroes until the pandemic. Now everybody knows just how much they do and how much they care. But I don't think as administrators, and I also come from that background, that administrators focused enough on wellness programs before the pandemic that they could have initiated early on and help many of the individuals who find themselves facing emotional crises, but feel that they must meet the obligations, the ethical obligations in their profession, and care for the patients that they're assigned. So we have that as a challenge. What do we do and how do we help them? And administrators need to take the lead and plan more effectively. I think another issue that we had, I think that you mentioned briefly, is what can we do about policy? There's so much we can do about policy. We can do policy in terms of what kind of programs do we provide? How do we provide easy access to care for everybody? Everyone now is aware that among African-American women, maternal mortality is just really going through the roof. But there's so many people that are unaware that those, as you mentioned, in higher economic groups can use doulas. We still have midwives, but midwives really aren't available to everyone. And they're not distributed equally across the country, where low-income folks could access the services of these midwives. So In terms of policy, I would encourage us all, because we should ask for and demand that our legislators continue to fight to keep, and I don't like to say ACA, but the Affordable Care Act available so that all people in the United States, not some of us, but all of us, will have easy access. Deborah spoke about the hospitals that were built early on to provide more access to hospital care for everybody and integrate some of these facilities. If we look at what has occurred recently, and even in New York State, we have closed so many hospitals, and most of them have been closed in low-income areas. So there's so many issues. And again, I want to thank you, Dr. Galea, for really highlighting all the differences that we see, not only in health issues, but also in education, in income, and in housing. Those problems, I'm afraid, will stay with us for a long time unless we have intervention with policy that makes sure that all of us have the access, irregardless of our ability to pay, or, and I'm very big on language or language skills. Peggy?
Okay, thank you so much, Carmelita. That really made me think a lot. In fact, everything everyone said is making me think a lot. I need a drink. No, I didn't mean that. Anyway, okay, Dr. Moore, or may I call you Donald? We're all on a first name basis tonight. So I'd like to introduce Dr. Moore. Let me just grab my copy. Donald Moore is a doctor, and he's also has an MPH. He earned his medical degree from Yale and his Master of Public Health in Hospital Administration, also from the Yale School of Public Health. He has a very extensive background, which I'm afraid I don't want to take too much of his time in reading it all. But I actually will mention that he is president of Provident Clinical Society, which is the Brooklyn affiliate of the National Medical Association, which is the largest and oldest national organization representing African-American physicians and their patients in the United States. He's also a board member of Physicians for a National Health Program, the New York City chapter, an organization I've supported for a long time. So with that said, please, to you, Donald.
Thank you very much, Margaret, Peggy. I'm happy to be in this position because I get to comment on the speakers. These are two really great talks. And I'm going to actually take them one by one. I'm going to start off with Deborah Gardner, and that was really an excellent presentation, the historical nature. It excites me to look at history. But Deborah, you said a few things and showed us a few things. The New Deal basically followed the Depression. It basically offered to African Americans supposedly an improvement in what existed before. We know what existed before. We know slavery existed before. We know Jim Crow existed during that time. And the New Deal basically was to improve the status of all Americans. But we know now that that's not what happened. Deborah, you talked about the hospitals. You talked about separate and unequal hospitals. That's what existed after Reconstruction. We know that the few physicians that were trained were not allowed to practice medicine in the same way that other American physicians practice. We know that Americans who sought healthcare could not go into a regular hospital in the South and get healthcare. If they did go to a regular hospital, they would have a separate entrance. They would be treated by a white physician in a separate place. And Black physicians, if they were able to get to medical school and get a degree, and many had to go elsewhere, they had to go to other countries to get their degree. If they did that, they still couldn't practice in white hospitals in the South. And the New Deal did not improve that. Even though, the Hill-Burton Act in 1945 said, okay, we're gonna fund the development of hospitals. We're gonna make it possible for healthcare to be delivered to all Americans. But we know at the end of the day, the hospitals ended up separate and unequal. So there was a new deal. There was a new deal for housing for whites and a different deal for housing for Blacks. Dr. Galea talked about the redlining that occurred. Yes, housing was made available for veterans after the war, but it wasn't the same. So we move forward to 2021. And now we have COVID and we have the opportunity for a new deal. I'm going to back up for a second. Dr. Galea pointed out that when Blacks enter the hospital, things may be a little bit more equal. But let me remind you, anyone heard the name Dr. Susan Moore? This was a Black physician, a physician that entered a hospital in Indiana with COVID-19. In the hospital, she actually made some Facebook posts. And the Facebook post basically said, I'm sitting here in a hospital with COVID-19. I feel terrible. I am dying, and this doctor wants to kick me out of the hospital. He knows I'm a doctor, but he wants me out of the hospital in the middle of the night. He did eventually get her out the hospital. She did eventually go home. She did eventually get readmitted to another hospital in a worse state, and then she died. So even when we get to the hospital, even when we get health insurance, in 2003, the National Institute of Health actually did a report. The National Academies of Medicine did a report. It's called Unequal Treatment. The experts then identified that even if a Black individual had equal access to care because of the racism that exists in America, even if they had equal access to care, they had health insurance, they got to the hospital, the outcome was still different. So what are we going to do in 2021? Everybody's talking about it. It's all out there. Okay, Blacks are more likely to get COVID. When Blacks get COVID, and if you notice, I keep using the word Blacks because I'm talking about Black people. Those are the people who were slaves. I'm talking about the Black people who were slaves in America, the history. Those are the people who experienced the racism through the latter part of the 19th century, all of the 20th century, and we're still carrying on the same thing in the 21st century. So it didn't matter. So even though we have identified the problem, even though the National Academies of Medicine, about 6 months before the first vaccine came, 3 months before the first vaccine came, actually laid out a platform to say, this is how we're going to distribute the vaccine. This is what our recommendations. It was put out there, but that's not what's happening. It's not happening. Even though we acknowledge that there is a disparity, there is inequities in vaccination, we still see the difference. Now, again, I will admit there are a lot of reasons for that. And, okay, it's not, okay, I will go and speak to the Black people over there and tell them to take the vaccine. It doesn't work like that. I'm a physician. It took me a while. I hesitated to take the vaccine. The reason why I hesitated to take the vaccine is because I didn't believe everything that was put forth. Why didn't I believe it? Because it wasn't all true. 95% efficacy after you have evaluated 170 people. That's what Pfizer did. 170 people out of 43,000 trial participants, and you're going to tell me it's 95%? Okay, 195 people were assessed by the Moderna, for the Moderna vaccine, 195 out of 30,000 trial participants, 94%. Well, we're seeing now in the real world, as we move further, we see that the Johnson & Johnson vaccine is only 66%. Why is that? The reality is when you take these vaccines, put them in the real world, assess more people, the efficacy is going to be less. But I took the vaccine. The reason why I took the vaccine is because I know there is going to be a vaccine class. There's going to be a class of the vaccinated and the unvaccinated. If I'm unvaccinated, I won't be able to go to the theater. I won't be able to go to school. I won't be able to get into my hospital, or I may have to prove that I'm not infected. So there are lots of issues. We talked about what happened in 1933 with the Tuskegee study. That was real. Our public health department in 1910, let me just share a quote with all of you from the person that was in charge of the public health of Americans in 1910. Basically, this particular doctor made the point. I really do want to share this quote because I think it makes the point very succinctly and clearly. It basically said, if a Black person shows, the future of the Negro lies more in the research laboratory than in schools. When diseased, he should be registered and forced to make treatments before he offers his diseased mind and body on the altar of academic and professional education. So this was Thomas Morell in 1910. This is what led to the syphilis study. Rosenwald met with the head of the Tuskegee Institute at the time, and they decided that syphilis was prevalent all over America, but most prevalent in the South. So when Rosenwald offered to help at that point, the intention was good. But when the United States Public Health Department got involved, it's people like Thomas Morell who designed and allowed the syphilis experiment to actually occur. So it's understandable. It's not because of Tuskegee why African Americans are hesitant for the vaccine. It's for the same reason I'm hesitant. The truth is not always there. So what is the New Deal? What can we expect from a New Deal? Well, the first thing we need to change is our structures. None of our structures have changed since COVID-19 came. As a matter of fact, all we've done is we've created ad hoc systems. No one has gone into the community into the community centers and said, well, let's improve the ventilation in this community center so people won't get COVID-19. No, we create tents outside. The monies, the billions of dollars that was allocated by our government, they didn't go into the community structure to change healthcare delivery. No, it went to major corporations, the Northwells, the Presbyterians. They took the money, but have they provided the service? Do they offer to do testing? No, they don't do testing. The hospitals don't do testing. Testings are done in what? The churches? Is that where we do? Is that we're doing vaccinations in churches? Is that where we do vaccinations? So my point is, there is no New Deal unless we go back and begin to address what goes all the way back to 1865 after the emancipation. We have to go all the way back there. We have to come all the way through Jim Crow, peonage, involuntary servitude, the separate, unequal treatments, and we've got to take it all the way into the 21st century. I'm gonna stop in a minute, but I wanna bring one more point. The point is, in New York City, we offer testing in different scenarios. If you are Black, you go to Health and Hospital Corporation. You go to the public hospital and you get testing. If you're Black, that's where you go for your vaccination. If you're white, you go to a different setting, a different place. You get tested separately, you get vaccinated separately, and you get treated separately. Until we remove these structures that's keeping Americans separate and unequal, we're really not going to change a lot. So I apologize for all these expressions, but it's very hard not to make these points when we're talking about a New Deal. But a New Deal can only occur when we actually uproot the structures that are keeping our society separate and unequal. Thank you.
Thank you so much, Donald. Oh boy. So I have questions that have been coming in for all of you. Let me just start with the questions that have come in for Deborah. She actually received quite a few, and I think the answers will be worthwhile. For one question came in asking, what was the program that became food stamps? Let me ask you just a couple more so that you can put them all together. I'm curious about that too. I didn't know about it. Another question, which agency designed the posters that you showed? Was it the Federal Art Project? And so a little bit more about that. And then third, for Deborah, do you think that it would be possible to create another CCC? I mean, that's a little off topic, but nonetheless, these all came in for you. And I hope that you can answer all of them.
Okay, thank you. I love the way that all the comments have kind of melded together in a very interesting, creative way among the entire panel. The food stamp program originated, I believe, in the Department of Agriculture, and it was funneled through one of the New Deal agencies. The Federal Art Project supplied artists or found artists or commissioned artists at the request of various other entities. So if you were in public health in New York, you might go to them and ask for an artist who would give you posters for a tuberculosis campaign. So the artists were hired through the Federal Art Project. And then they worked on those specific commissions. And then the third part was the CCC. I think it was a marvelous program. It saved the lives, literally, of many young men and many families, because the young men who went to work were malnourished and often in ill health. That was taken care of. Their money that they earned, 3/4 of it was sent automatically to their families to support their families. So for every young man working in the program, you had a multiple of whatever, 2, 3, 4, 5, 6 people who were being helped by that program. At the same time that this young person was also building these amazing facilities and taking care of our environment through land conservation, land rebuilding, parks, and so forth, which were available then to millions of people. And I was kind of disappointed in a way at the beginning of the stimulus period, it's almost 10 years ago now, I guess, that we didn't have some kind of programs like that available to young people. Certainly the need is great, for example, in the national parks, which have backlogs of billions of dollars in needing maintenance. Now, I just want to say something to Donald about the New Deal and how it handled race. You know, we have to contextualize. We always have. This is not to say we can excuse the problems, but when you understand, for example, that President Wilson, FDR's predecessor by a number of years, was an out-and-out Southern racist and bigot and got blacks fired from their jobs in the federal government, where many of them earned a decent living wage. FDR had to, in a sense, rebuild based on that. And he had African-American advisors, including Mary McLeod Bethune, who was a personal friend of the Roosevelt family and certainly influenced them in their views on race, especially Eleanor, who later became a member of the NAACP and was always speaking out against racial prejudice. And the fact that they built separate hospitals, they were building good hospitals either way. When they built public housing, they were building decent public housing, whether it was for white families or black families. So there was a certain amount of equity that is hard to see from this historical perspective that was going on there at that time. And there were also African-American Ccc units. So while you had segregation, at least the scale and the quality, so to speak, of the programs was equal to that was being provided to whites. And some pictures that you've been seeing was an African-American doctor treating white patients in Illinois, which was probably unusual, but was kind of matter of fact. And many African-Americans and Latinos who ended up in migrant camps were able to take advantage of the health services that were offered there. So was it unequal in a way that we see it today? Yes, but for the era, it was progressive. So it's too bad we can't have a similar progressive formulation today.
Thank you. All right. Here's a question for Dr. Galea. If there is there one immediate thing we can do, or if there were one immediate thing we could do, rather, what should it be? What's the best thing we could do right now?
Yeah, it's a terrific question. I'm often asked that question. I think the best thing we could do right now is to talk about health differently once and for all. I think if we stop thinking that we are going to fix our health by focusing on the biological, by focusing on the treatment for malaria, to extend that metaphor, I think a lot of other things will follow. It is simply not understood around the kitchen tables of America that the most important thing for health is politics, that the most important thing for health is education, the most important thing for health is better neighborhood, the most important thing for health is ending racism. And I feel like if we can change that conversation, everything else will follow.
Great answer. Thank you for that. Here's some questions that have come in from around the country and the world. Wow. So here's a question from Sylvia in Albany, California. How can we address the equity issue in distributing the vaccine? And then, of course, I would add, and on the demand side, how to overcome vaccine skepticism, which you actually have addressed, Donald, quite a bit. But anyway, how, concretely, how can we change the way that the vaccine is being unequally distributed?
If I may jump into this one, the vaccine hesitancy, vaccine skepticism. It's not unusual for a population to be concerned when you come up with a brand new novel treatment in a rapid period of time, that people would say, well, wait a minute, I need to see what happens. But there is almost an attitude by our public health officials, well, you got to get this vaccine done now. You got to get it done now. If you don't get it done now, then you're going to harm not just yourself, but you're harming the rest of the population. Some people just need more time. I think we'll overcome the skepticism, the hesitancy, by providing information as it becomes available. We started out 95% effective for Pfizer, 94.1% effective for Moderna. And then within a few weeks, we heard, well, there are new variants. Well, we always knew there were going to be new variants. And so a discussion has to continue. And those skeptics that were saying, well, I need to wait and see, well, they're correct. They're right. Wait and see what happens with the variants. Is my vaccine going to be effective against the variants? Will I need a third vaccine? Will I need a booster? The flu shot is every year. Is it going to be like the flu shot? We don't know the answers. I certainly don't know the answers. But if I say to my patient, yes, your question is an appropriate question, I will work with you. As I get information, I will help you to interpret what is going on, because I'm a physician. I should be able to help a layperson interpret the data as it's coming in. And I think that's how we overcome skepticism. It's not, okay, you will do this, you will get this vaccine, you will line up over here and you will go there to get your vaccine. People are going crazy doing some very unusual things to get these vaccines. Why are we traveling all over the place? Why are we registering multiple times to get the same vaccine? What kind of system is this? Maybe it's the same system that we have had all along that causes excessive infant mortality, excessive maternal mortality, low life expectancy. Maybe that's the problem. And the people are saying, well, these are problems, let's fix it. And we're covering our faces and say, well, no, we're just going to fix it with a vaccine here, take the vaccine, it's over. So thank you.
Thank you.
Can I just add one thing to what Donald said? I'm also looking at time, I'm going to have to leave in 5 minutes, but I actually thought Donald's last sentence captures the entire thesis of what I was trying to say. Because you said, we're going to have the vaccine. Our thinking is we're going to do the vaccine and we're going to just fix it. That's exactly the point of my entire talk, which is the therapeutics do not just fix anything. Sure, they may deal with the particulars of the virus, but fundamentally, the problem runs much deeper than that. And what's going to happen in 2021? It's going to be a raft of books about therapeutics and about vaccines and about biodetection, biosentinel sites to prevent next pandemics. And when another pandemic hits, we're going to have the same disasters we had now if we don't deal with these fundamental issues.
Well, I also want to suggest, though, that it might be helpful to look at previous vaccination campaigns a little more deeply to deal with our current crisis. For example, there was an article in the Times recently about the smallpox scare in 1947. and how they vaccinated over 5 million people in 1 week. Now, the city had about 7.8 million people at that point. Presumably, the rest of them got vaccinated pretty quickly. But people went bam, bam, bam. They were told there was a problem, and they lined up. When the polio vaccine by Jonas Salk was declared effective in 1955, people lined up to get vaccinated. And by the time the Sabin vaccine came along a few years later, they had to go abroad for the testing because everybody was vaccinated. How did they persuade people that it was in their best interest at that point to get vaccinated? I mean, are there lessons for us? Because those were terrifying diseases, just like COVID. COVID may even be more terrifying, I don't know. But they managed to do that. So at the same time as we look for this broader response, which Sandra and Donald had talked about, besides the unique healthcare response, I think it might be helpful to find out what were the persuading points at those previous times that got people out to be vaccinated to save their lives.
I think it's good to learn from history, but I think we have to look at what is the population makeup today, what is the geographic distribution, and where, in terms of geography, are the highest number of cases, and where do we have the capacity, the capability, the willingness to want to do what is necessary. And yes, indeed, we should have learned from past pandemics. We should have learned from past, public health messaging, but apparently we haven't learned enough. And I think that it'll take the collective effort of everyone. So health professionals, as well as policymakers, and not to be excluded, community groups as to where do we go from here? Let's plan now and not wait for another pandemic to decide how do we handle it.
Thank you. Well, I can't believe how time has flown. It's almost 9:30. I do have one question I would really like to engage you in, but I'm in a way hesitant to do so because I think this is, we're kind of inching toward it anyway. Now, obviously, one thing that we need is some form of universal health care, everybody in, nobody out, as the late, great Quentin Young said, who was a major advocate for single payer in this country before it became known as Medicare for All. I will be bold and say that I favor that. I think some of us also favor that who are here this evening. That isn't, it's a necessary but not sufficient condition for what we need, because preparedness long-term will take much more than that. However, I wonder if, this is the final question that came in from Catherine in Berkeley. Public health examples from other national healthcare systems that could improve American public health, ? Can we say that countries that have single payer or have socialized medicine are doing better? Are they not?
Well, let me Peggy, try and answer, and then I'm going to sign off because I had a hard stop at 9:30, but I couldn't resist answering this. The short answer is yes, because the evidence is that compared to other high-income countries, we live sicker, shorter lives. That's the short answer. I don't like the term socialized medicine because it's so politicized that I feel it's not helpful. But the longer answer is that I don't think that the reason for that is fundamentally the universal healthcare. I think it's fundamentally because the countries that have invested in universal healthcare also have invested in many of the other forces that produce health. So I go back to my metaphor. I think they have a better goalkeeper, yes, but they also have better 10 other players. Mm-hmm. I will leave it there. Thank you, everybody, for having me.
Thank you so much. Good night. Thank you. So anyone else want to weigh in on that before we conclude?
I'll weigh in on it a little bit. I just want to follow up on Deborah's point. In 1947, when we did those smallpox vaccinations, a pandemic was not raging. And if you look at photographs from that time, people were lined up 8, 9 deep to go in and get their vaccines. One story, my patient went on a bus, a full bus, from their assisted living facility to a hospital in this bus that was not ventilated to get a COVID-19 vaccine. Wow. So we're practicing today in an environment where we actually need to be aware that there is a pandemic. A single payer healthcare would do at least one thing. It would remove the fragmented healthcare system I mentioned earlier. This fragmented healthcare system where some people are getting their healthcare as they did back in the 1930s and the 1940s in a separate facility, in a separate hospital, in a separate situation. A single payer healthcare would at least remove that aspect. It won't solve the whole problem, as Dr. Galea said, but it would at least remove the fragmentation that we have today.
I agree. Carmelita, do you agree?
I agree, but I think we have to start someplace. And I think if we have a program that provides care for everybody, you know, we could look at the system in Canada, and you speak to some Canadians, they love it. Others don't. If you go to Germany and you speak to those folks, you have the same thing. If you go to the UK, there are people who love their system and those who don't. They say, well, the National Health Service doesn't work for me. So I think what we need to do, yes, we need some model, whether it's Medicare for all or we want to call it single payer, but we need to look at the countries who have had some success in caring for the entire nation and take the best pieces from all these countries and look at what our needs are and come up with what will be best for all of us.
Okay, thank you. That seems like a great note on which to end. So I'd like to just thank all of you so much. It was really an honor to be part of this, and I hope it was as good for you as it has been for me. And I'm definitely will be in touch with all of you soon and follow up. And I hope that our paths will cross again very soon.
Thanks, Peggy, for inviting me.
You're so welcome. Good night.
Thank
Good
you
night.
very much.
Bye-bye.
Bye. Bye, Deborah. Bye, Donald.
Bye.
Bye.
Bye, everybody.